Thanks, Ash. Ash, do you know what number this is?
Mm, I don't.
27.
21. 21.
21. I was
I was gonna
close.
say 20.
Yeah, you're close. 21. Well, awesome. Well, first of all, thanks, Ash. Look, its numbers just keep coming up. This is
I know this is
unbelievable. We've
awesome.
got such a great group tonight, man. This is unbelievable. This is thank you guys for joining us. Thank the sponsors. I'll introduce everybody real quick or let everybody introduce themselves. My main man, Phil.
What's up? Phil
Where
Page,
were you at?
Baton Rouge, Louisiana, Franciscan University. Happy to be here. Thanks to Ashley for pulling all this together. And of course, our sponsors, and our guest. Can't wait to learn more about the hip tonight.
Oh, it's gonna be awesome. Awesome. Barb, tell everyone about
Hi,
yourself
I'm
quick.
Barb Hoogenboom. I'm the editor-in-chief of IGSPT and super happy to learn with all of you tonight. Thanks to Ash and to Phil and Rob and Robroy and Dr. Christoforetti. Thank you very much for coming.
Awesome. Thank you. All right. And then our two favorite men of the hour here tonight is Robroy Martin and Dr. Christoforetti. Rob, tell everybody about yourself real quick, and then we'll let Dr. Christoforetti introduce himself, and then we'll hit it.
So I'm a professor at Duquesne University in Pittsburgh and have known Dr. Christoforetti for an awfully long time. So I'm very happy to join him in this very good crowd we have here and host. So thank you for the invitation.
Thanks, Rob. Dr. Christoforetti.
I'm John Christoforetti. I'm here in the Washington, D.C. area. Although I've had a little bit of a circular path in life. I started here, and then Rob, after I did a little training in Vail, he found me in Pittsburgh, and he said, Christoforetti, are you going to do anything meaningful? Are you going to actually collect outcomes? and I said, I don't even know what that means. And then he convinced me, and he taught me how to do to become a better surgeon by collecting outcomes. And so I'm proud to be here with you guys.
Awesome. Thanks for joining us tonight. We really appreciate it. Both of you guys, I really love listening to both of you guys talk. You guys, when you do your talks and lectures, there's always something that we can pick out from it and that we can use clinically. So it's great to have you here on the Journal Club with us tonight. I'd like to start, I guess, let's start with the first article of, I think it's Hugenberg. Is that how you pronounce it, Rob Roy? Hugenberg?
That's what I would go with, yeah.
Okay. All right.
Sounds like Boom to me.
Boom. Hers is going to be on another episode. But this is clinical commentary, a criterion-based testing protocol for return to sports post-hip arthroscopy for impingement. All right. This is a really good one to me. I found a lot of interest. I have a lot of questions about this because I like doing a lot of functional tests. Or I guess I don't do a lot of functional tests, but I do functional tests for a lot of knee patients and a lot of shoulder patients, so I have a lot of questions about this one. You know, how does this really differ in the hip than it does in the knee? So I guess my first question for Rob or Doc are what does well, I guess you guys can tell us, what does return to sport mean to you for or Ash is back too, so she can answer this as well. I thought maybe she was leaving for a minute. What does return to sport for hip patients mean to you? And is that different than any other return to sport for the lower extremity? So if we're doing return to sport for the foot and ankle, or we're doing return to sport from the knee, is it really the same thing for someone with hip problems? This is specifically talking about after arthroscopy for hip impingement, but would it be different for any other hip problem? What's your kind of general overall take on return to sports for hip patients?
Yeah, so the first thing is the problem with the definition of return to sport. So, I mean, that's kind of one of the quagmires that people get into is really what is return to sport? Return to sport for an older individual who wants to get to, recreational pickleball once a week is different than a professional athlete. So I think the real problem comes in defining what's return to sport. So I think there's been some, consensus with some experts trying to really get a handle on that. So when we read articles about procedures, we're talking about the hip today, so hip arthroscopy and what a return to sport rates, they're really hard to interpret because you're looking at a full spectrum of return to sport, and return to sport doesn't mean to return back to your previous level necessarily. And that's what I would be, I would take that return to sport definition as, are you able to return back to your prior level of competition and ability. So that's how I would take it.
Doc, you have anything different on your take or what you consider return to sport, at least for hip patients?
Well, I think that you've got to echo what Rob says. Nobody knows the literature better than him. And I think Mark Safran really kicked this off well with this group from Stanford. Actually wrote a paper maybe within, I suppose, the last 2 years, maybe 2021, that he wrote a paper about the problem associated with defining this in our literature. And I agree with Rob that, it's about going back to where their last level was, or maybe only nuance I might add is many times in the hip versus in the shoulder or the knee, they're in transition. So whether it's a minor league baseball player wants to go up to the major leagues, whether it is a high school player that wants to play into college, and you have a difficult time with those players. And I think because oftentimes they get to the end of their peak performance on their last leg within that level of participation. I'm not sure if you're the group's experience, but versus an ACL, you can injure an ACL obviously as an Olympian, or you can injure an ACL as a high school athlete, and so therefore I think that some of these may be more comparable to what I see in thrower shoulder breakdown in baseball as opposed to the ACL. So I think that some of that is about where maybe the hip may nuance for me a little bit in return to sport, and that you see that fatigue factor end of the road for level that they're at, and then the return to sport becomes even more difficult because they may not have an option to go back to high school sports because they were a senior, and then they never got to go on to be that freshman. So I don't want to say too much, but that's where I think that the challenge is. And we didn't even worry, what about practicing for the sport versus if they're really good, did coach let me back on or did he not? Or did she not? So I think some of that is also politically involved with it that's difficult.
No,
Yeah,
great.
and then kind of hip specific stuff. I mean, you asked the question, is it different than the foot or ankle? And I would just say, some of that again is going to be a little bit sport specific. If you're a catcher who needs full flexion, that might be different than someone who doesn't need to require, maybe they're doing, stuff on both legs that don't require a lot of flexion. So I think incumbent when you do surgery and impingement, we're looking for to increase generally hip internal rotation and flexion strength. And then there's usually some glute muscle weakness that goes along with that. So those would be the little nuances that I would say might be different than another joint specific.
We had a talk a couple episodes ago about return to sport, and we were discussing whether maybe return to sport shouldn't be hip specific or knee specific or shoulder specific, but maybe the return to sport testing should be more actual sport or even position specific, because you're right. I mean, a catcher has totally different expectations than a hockey player or something like that, right? So maybe we shouldn't look at them in regard to the actual joint, but maybe positions of sports that the people play are like a golfer, is totally different than any of those people. So, maybe we need to look at it differently than we do. I mean, from a total different lens. What do you think of that, Ashley? We talked about that before, didn't we?
Yeah, and that would be my main comment. And I think we should, like you said, I think we should maybe do this across all injuries or surgeries. But in the hip, I find myself very much when people say, well, what are your criteria to return to sport? And my next question is, well, which sport? Because I don't have a set criteria. And I have certain criteria to move into that, like return to train, return to play, like progression phase, that they have to meet some minimum requirements to be allowed to do that. But when you say, like, what are your criteria to say, like, yes, you get to go back to your sport at 100%, a golfer is much different than my Major League Baseball catcher, than my female soccer player, than my tennis player, whatever. So I do find that we tailor it a lot more to the sport and the activities of the sport specifically than saying, like, well, you have to pass these hop tests.
Yeah.
Right? Like the tendency with ACL, like, you got to pass all these hopping tests. Well, okay, hopping doesn't really mean much for my golfer.
Yeah,
so.
they're not going to hop at all. Never. Well, maybe after a good
Well,
shot. Maybe
power
a
guys
really
kind
good
of.
shot. Yeah. Exactly. Well, this here's another question I have for you guys that I was wondering about as I was reading this, and this really doesn't have as much to do with the functional testing, but the authors here in the introduction were talking about the different studies that show different treatment options are better for people with hip impingement, and they were like talking about the fact that you can do injections with people, you can treat them with conservative therapy or surgery, and really depending on, it sounds like to me like depending on the study that you looked at, either any of those people getting injections alone, by themselves, people just treating conservatively without injections, and people treated surgically. There's a study showing that any one of those really do well uh, after that type of treatment. So my next question really is probably for Dr. Christoforetti more. What do you think is better in your hands? Do you feel like you do really well with people after they get an injection or after they send them to conservative therapy, or do you actually feel like, if those fail, surgery is really the best option for them? Or do they all have their own, obviously they all have kind of their own time, right? Or their own place, and what works best in your hands?
I'm smiling because you think you're going to get me to say that therapy doesn't work or something on this type of forum. And like, is there a tomato function that could happen here in Zoom for me to get hit with? I mean, in fairness and in seriousness, I would go back to honestly, I don't know the answer about these comparative studies when we talk about real athletes, because from my perspective, femoral acetabular impingement syndrome, which Rob and this group, frankly, has helped everyone understand in their consensus statement, is the symptom and the syndrome associated with the radiographic findings. I mean, the x-rays that show impingement, then we have the physical examination findings, and we have the patient's problem, which in my hands means their sport is not working to the level of that they can perform if I'm going to be operating. And in those patients, they've all already had any one of you or two or three of you come and tell me, Dr. C, they are definitely something that we cannot get them better for. And we like to define a timeline so both you and the patient don't feel frustrated, from a perspective of there's no access to care, right? But that's where the concept comes so much into play. So I don't want to dodge the question. It's just simply that I have not ever operated ever on a patient in all these years that hasn't had this access to physical therapy. So I don't have the information to give you. And I also would suggest that some of these studies that might talk about this potentially, and no criticisms to any authors internationally, these are wonderful studies. It's just in the United States and in competitive athletes, I just simply don't have any experience with someone that's truly a competitive athlete that's coming and electing for an operation before they've talked with a number of conservative modalities. So, or if unfortunately they've read something and it's gotten in their head, then the role of us as a surgeon and as a team, my feeling is completely to help reassure them using whether it's prevalence data. One of these articles quotes a relatively lower number for prevalence that we've seen in subset populations. It's down in the 60%. I'm thinking we've certainly seen papers in the 80, 90%. So in the end, for the international listener, the question is, what about the research that's been done, like in the fashion trial that randomizes and goes prospective in the UK? Wonderful study. What about these studies? They show incremental differences in regular populations. If we take sporting populations, true active competitive athletes, there is no study that randomizes this, to my knowledge. Rob, are you aware of one that takes active athletes and does this? So this is something that we have to be careful that, and I'm going to say this without preaching, if it's okay. Patient values, expert opinion, and best published evidence, and it's the confluence of those things that's where we get our evidence, not just a study that comes out, right? So from my feeling is with that three type of circles, the patient value circles keep surgeons from operating right away if they understand they don't value being out for surgery if they don't have to. So that's my thought.
Yeah, love it. Anybody else have anything to add?
I mean, I would just add, like, if we're kind of trying to identify who might benefit, is, obviously PT is not going to change the bone on bone interface, but we can change how people move. So that's the big thing to me, is if I can improve movement, those people may be the ones that can improve. If the bony deformity is so large that we can't improve their ability to move, then those are the people that go to surgery. And I think it's generally accepted that you go to surgery earlier if you're the more active you are. So we don't want to squander these people time away if they're going to
if it's something structural
fail,
or something that is anatomical that needs fixed. Yeah, makes perfect sense.
I was looking for the amen comment on Zoom, and there wasn't one. So
I think the other thing too, just as therapists who are getting these questions from patients, like, well, I heard this, or I read this, or someone told me this, a thing that by nature of who I work with and what I do day to day is, well, someone told me that the success rate of this surgery is like super low and the revision rate is super high. And it's hard as a treating therapist to stay on top of all the research that's out there, but just always keep in the back of your mind the stuff we talk about on these journal clubs is like the quality of the research matters. So you have these papers out there that say surgery doesn't work for FAI. Well, okay, if you read the abstract, you might take that away and be like, wow, this really doesn't work. But if you dig into what actually happened in that study, there's a couple papers out there that I see getting. I just went to a Con Ed course not that long ago, and they quoted one of these studies that I was like, this is such flawed research, to the point where AJSM put out a statement about it. like you guys can't cite this research and tell it these therapists who don't have time to dig into it day in and day out to figure out what's good and bad. So that's where I would say is like, these patients are going to come to you asking these questions. Just know that unfortunately some of the research is very flawed that's making these statements, but surgery also is not for everyone when it comes to these people. And that's where we know what to look for to know who's going to do well and who isn't. And with Dr. Bird, to quote Dr. Bird, like, just be a good picker.
Yeah, no doubt. That's
I wonder if I could comment about this. And Ashley, what you said, I think is perfect, because look at the criterion in this article, and we say 5 degrees, within 5 degrees of the contralateral rotational side is a return to sport criterion. If I were to have used that in any of the years that I were involved with either spring training or MLS entrance exams from the hip side, or any of you that have examined large populations of healthy asymptomatics, many of our players, wouldn't pass this, that have never had hip pain a day in their life. And that's, I think, the confounding factor with the sort of all or nothing phenomenon in either group. In the end, it still comes back to, doesn't it? If the movement that's lacking is critically essential to the performance of the job they need to do, then they notice it. If they can't work around it, like Rob's talking about, and if that's a fixed mechanical obstruction, I have a question which isn't addressed in here, because in the end, this takes information where we used to think the cam lesion was the primary limiter of range of motion. Mm-hmm. As we've evolved to understand as surgical teams that it's the torsion or twist of the femur, largely to femoral retrotorsion, like in a skiffy, the most extreme example, where the patient has the out-towing, right? Those are probably the ones that we most effectively can identify with limited range of motion, are going to be femoral torsion abnormalities. I think we've seen a couple of studies, Rob, show us that our range of motion examinations, we focused originally on guarding or pain-based limited motion, but what do you all think is therapy? And I'm interested in this panel of experts' thoughts too about this 5 degree of difference side to side. As you all are evaluating this, should I be considering this more and examining these both and looking for the difference, like in GERD, or what should I do?
I think that seems a little crazy, because the error in measuring goniometry is 5 degrees.
That's
so
what I was about
just
to say.
5 degrees is hardly, like, it's negligible.
We need to, as clinicians that are reading the literature, again, be very critical, look for those confounders, the bias, and just understand that the minimal detectable difference of these devices is so important. And that's why we preach the importance of being a critical appraiser in the literature. And students don't always get that, right off the bat, until you get out there and go, wow, I guess I should have paid attention in research class. Because that's the kind of stuff that we preach, is that 5 degrees, that's all, that could be error, no problem at all.
And don't some, I mean, are there a lot of sports that, I had mentioned this in the questions, that like are kind of like the thrower's shoulder, right? There are certain, like a golfer doesn't have symmetrical hip range of motion, right?
Yeah.
Is that right, Ash?
They can be asymmetrical to some degree. And also you have to think about, like, how does it affect their game? Like, is it their trail leg? Is it their lead leg? How important is it? And to Christoforetti's point with, version issues, I've seen people who have, significant anaversion on one side and fairly normal other side. It's like, you got to know what that looks like, because if you're not comparing apples to apples at that point. So
one of the anecdotes that's my favorite about Dr. Bird is that he called me one time, and I was in my operating room in Pittsburgh, and it was early on, and he said, "Didn't you go down to the Rockies and take pictures of their X-rays?" and get these done radiographs. And these are radiographs we take with the hips in a certain position. And he said, how did you do that? And I said, well, we took this pillow and then we took duct tape and put this other thing on top of it. And there was a little room in the back. And, basically Todd Mitchell and I and Rich Hawkins said we were going to measure GERD with a goniometer and do this thing. And we only have so much space. And he said, well, thanks, because he's trying to figure out how we did it, right? And his curiosity drove this. This is 2006 when we did this, right? And we're looking at it. Ultimately, Phil, your comment about those ranges, we were trying to correlate GERD at the same time as we were trying to correlate range of motion differences and take those x-rays. And we did it with some, it was Rich Hawkins, Mark Philippon. It was the two guys that didn't know anything, Christoforetti and Michener, and Tokish. And we're measuring all these things down there. And I'm gonna tell you what, those numbers were all over the place with the goniometer. So, and a bubble, like Keith Meister said. When I look at all that stuff, I just look at the numbers and I'm like, man, I know we have to pick a number, but 5, that's something.
Yeah. I was thinking the exact same thing.
Yeah.
What did you guys think about? I guess this probably could be okay, but this what concerned me a little bit was that according to the article, the patients that they looked at, they did their actually testing anywhere. So after arthroscopy, they did their testing anywhere from 3 to 12 months after surgery with an average of 7. Is that typical? Or we usually test someone at 3 months, or do you usually wait a little longer after arthroscopy? And or why would you need to wait till 12 if they had arthroscopy with no real other complications?
Yeah, and again, I think that comes down to the lack of definition of what return to sport is. Like, for me, when I'm testing at 3 months, I'm testing for like readiness to start the progression to the return to sport, versus at 5 or 6 months where we're trying to clear them maybe to go back to play. I certainly, I don't find myself getting into situations where that's happening at 12 months unless the person has had like a staged one side and then the other. And so maybe they're getting closer to that year mark in like the total timeline. If we're getting to 12, that means we've run into problems along the way, at least in our patients.
Yeah. What do you think, Rob? 3 to 12 months, pretty big range for you too?
Yeah. And, it depends on the surgery that was done, right? The age of the patient, the quality of the tissue, what were they going in like? There's just so many variables that, different surgeons have different protocols all over the world. We go to these issue meetings and there's a large range on when physicians allow people to go back. So I think it's very hard to just throw everything into one pile and say, this is what's right for everybody.
Yeah, that's kind of what we did with this study, I think. They also said that return to sport testing seemed to be faster in their population, faster in professional athletes, pediatric patients, and those with shorter symptom duration. I think maybe I understand that, but I wanted to see if you guys could elaborate on why you thought maybe that would be.
Well, some of it might be money driven. For professional athletes, they need to get back quickly, so they're not going to necessarily, they're pushing the envelope.
Is it money? Would it be money driven, or I was thinking even more just of their if you're at the professional level, your physical abilities are probably better than like yours and mine, right? So is it maybe because of their physical abilities they naturally have too? I think money would be also, but
I mean, that and resources, their whole job is to get better. They get rehab daily, if not more than once a day. They have also access to anything and everything they need. So compared to, your middle of nowhere high school kid that doesn't even have an athletic trainer at the school.
Yeah. And the shorter, my guess is that you guys can tell me the person with the shorter symptom duration, they probably just don't have as many other comorbidities or other problems that you'd get if you've had this problem for 6 years, right? I mean, I think. Now so how about the pediatric patients? Is it just because of their age? Why would they be quicker?
I mean, I find that they just bounce back faster for the most part. They don't have as much like reservations or hesitations already kind of preemptively built in. Usually if they're pediatric, they haven't had symptoms quite as long because they haven't been around as long.
So the shorter symptom duration and being peds may kind of go together. Yeah,
well,
Doc, you're getting ready. I can see you're thinking something. You're wanting to say
these
something.
are such great comments, because this is, look, the other thing that's, we're not, maybe in 21, the right thing for us to think about as surgeon plus therapist teams is return to sport. We haven't even figured that out yet, but we probably need to think about what Bankart Repair did with ACL reconstruction does. You can get back, and then what about if you re-injure the next season? So we're also about staying back, right? And we have to talk about durability upon return. Now, in seasonal high school athletes, very few parents will allow their child to miss their sophomore and junior year for any orthopedic injury in this country, at least in the United States. And I'd love to, hear what the international community is saying about in their countries. But if you tell a freshman you're going to be out for hip surgery, it would be rare, both in my Texas years, my Pittsburgh years, or now my DC years, to see those local families say that their child is going to go ahead and wait till they're a junior to play, or even have a chance if they were going to do that by the time life passed them by. So I think in the way the U.S. secondary education goes is probably where some of that pediatric is really adolescent, and there's probably some of that. The other comment I would briefly make about professionals and these times are longer than those successful athletes that we're taking care of, and we've shown that in some of our outcomes. Obviously Dr. Bird has shown it, and multiple groups have shown it, that you can have successful return. Dr. Philippon clearly led the way with it, where you're really looking at more like a 4 to 6 month arc for primary femoroacetabular impingement arthroscopic surgery. And we have lots of data to support in level 4 series or such, which they're referencing. So I think the math is a little bit skewed potentially in this one, because I think this is a longer time than what we're imagining that we are shooting for. I don't know if I'm misinterpreting that, Ashley or Rob. Do you guys? I mean, we're thinking more 4 months to 6-7 months at the delay window when we're talking about a primary for all levels. What are you all thinking?
Yeah, I agree. I mean, I think that's, it can be a little bit longer. And again, it all goes back to some of it, how rehabilitatable is a person, right? What condition are they going into? I just maybe bring it back to the knee. You have a 50-year-old, someone who has a meniscectomy, and you have a hockey player who has a meniscectomy. The hockey player's out on the ice within the same week, and the 50-year-old wants to know why she isn't back to pickleball in 12 weeks, right? And it's the quality of the tissue, it's the health going in, it's their whole ability to move and control movement, and obviously higher level athletes are going to excel in all those areas.
Yeah, I mean, our general answer is 4 to 6 months for a primary, not a revision or anything. But I've had a bull rider send me a video of himself on a bull at 8 weeks. No problem.
Well, they got to work.
Yeah.
They got to work, damn it. If they don't ride, they don't make money.
Nope.
Those guys are crazy.
With a microfracture, by the way.
Yeah.
He's supposed to just be getting off his crutches, and he's on a bull.
They'll have macrofracture soon.
Yeah. Is sitting on the bull really weight bearing? Maybe that's considered non-weight bearing.
There is an argument there.
It's an argument. It's not a good one, but it's
just cheese.
Rob, you brought up pickleball. I thought that could be a whole new session. That could be a whole journal club, just pickleball in itself. My God, it's just unbelievable here.
Do you guys think about this? I'm curious what you think about this. So if you look at outcomes, which Rob taught me how to do, and you are a surgeon, which I suffer the only fate of that part. So and you're there and you're the one who does it. If you operate on a self-limiting condition, meaning it's going to get better anyways, those are the shorter duration symptom patient, right? So this is someone that's got quick symptoms, a readily identified radiographic finding, and a highly prevalent MRI finding of labral tear. And they have symptoms for short time. The reason potentially their return to rate is better is because they would have gotten better anyways. And the surgery that you did just didn't knock them down. So I think that one of the things about outcomes research is that it points out, and I'm not suggesting people that go early are always done wrong, so I don't want to be misquoted on that, but I'm suggesting it's a flaw in the threshold for surgery, because if you are safe with antibiotics, you're good with post-op rehab, you're safe with your portals, we've invented an operation internationally now as a team of people over 20 years that lets us take a patient, put them to sleep, wake them up, and usually not harm them with the surgery. So if a lot of it does come down to how compatible was that athlete outside of that little tissue damage that was keeping them from going. And I call it the princess and the pea phenomenon. Like if really there's that one little tissue that just couldn't get them responding to your treatments, and you can address that, and they haven't hurt for long. This is a whole different circumstance, isn't it? And
it's a total different patient.
Yeah.
Really, compared to the average probably that you see. You're exactly right. I agree with you 100%. So what, one of the things they also talked about, which I think is really kind of, at least I see on social media, and we talk about it at meetings, it seems a little controversial, is the limb symmetry index. Okay, so we have a limb symmetry index that someone should return to. The standard number is 90% when they're doing a unilateral hopping, jumping type of activity. And so they said the limb symmetry index should be about 90% with the return to testing. And we see a lot, not everybody, but a lot of times in other surgeries where after you have the surgery, the actual uninvolved side actually gets a little bit weaker. So then when you do the test on the involved side, because the uninvolved side is weaker, when you compare side to side, it actually looks better. That has to happen in the hip too, right? So is the limb symmetry index of 90 good enough?
Well, I mean, I think this goes back to the whole thing. You got to have multiple criteria, right? So you can't hang your hat on one thing.
Okay, I'm asking you to hang your hat on one thing, Rob. Come on. If you had to
Can
hang
they?
your hat on,
It's all about movement. Do they have enough strength to do the movement that they want to do? Can
well,
they
they had
control the movement?
90% limb symmetry index. Would you?
Can they?
What does that
Can they
tell you?
move? Well, that doesn't tell me anything about how they move or control movement.
So you don't. Then you don't like limb symmetry index at all.
Not as a standalone test.
He's qualifying it now. He's qualifying it now. He's breaking the rules here, guys.
I mean, you have to
It's a
also
piece of the
realize
puzzle.
with the hip too, compared to like an ACL reconstruction, most of these people, if not all, have at least FAI morphology on their uninvolved side. If not a little bit of FAI syndrome, maybe it's just not as bad as the side they had operated on. And with that comes some pain inhibition at times, even if it's sub like clinical pain level that they have, they may have some weakness on their non-surgical side that's relevant to their underlying FAI. So, what are we comparing it to is another thing versus like a traumatic injury where I tore my ACL and I didn't tear it on the other side. So I agree. There's just too many factors that go into it to hang our hat on one thing, no matter what it is, range of motion, LSI, whatever. That's why it has to be.
What if you're looking at strength? Does strength matter?
I mean, certainly
What if
strength
you're looking at,
matters.
yeah.
I mean, if someone that just has like terrible strength, we're certainly not going to put them back out there. But if they have terrible strength, the likelihood that they're going to move well, to Rob's point,
That's
is
good point.
probably
Good point.
very low.
Do you have I know in like knee, when we test knee patients, we look at their limb symmetry index, but we also, instead of just looking at side to side, comparative side to side, we also look at certain speeds and compare it to their body weight so we can allometrically scale it individually to them. Do you have that in the hip? Are there strength tests that you can allometrically scale to the hip? So for like hip abduction and extension strength has to be, a certain percentage of their body weight or something. If you're looking at foot pounds on an isokinetic machine, do you have that, or is that not even known?
Yeah, I'm not sure how many people use isokinetic largely just for the time constraints related to it. And what are you really testing? I mean, the hip largely is going to function as enclosed kinetic chain as a stance leg. And if you're testing open chain movements at high speeds, I'm not really sure you're getting at what you want to get at. So, we don't really use it that much in the clinic for hip patients just because it's very time consuming and the value it provides is fairly low.
You do manual muscle testing then mainly?
Yeah, handheld dynamometer in some
Yeah.
cases, right?
But theoretically, couldn't you do a torque to body weight ratio or establish? I know it's probably not in the literature yet, but theoretically you could do that for musculature of the hip in an isometric, like even just using a strain gauge, right? And there's algorithms for figuring that out. I mean, that's a possibility. I mean, we're getting there with the knee, I guess, but the hip is probably a little bit in the back seat at this point.
Yeah, a little behind.
Mhm.
Yeah. What do you they're talking about single leg bridge. and how during the single leg bridge you can use it for the glute or for the hamstring. Do you guys use both? What do you look at when you're looking at the bridge? Are you looking at hamstring more? Are you looking at glute? Do you do it for both? How do you vary that? Or do you? I
Well, I
guess
like
this is a
single
Rob
leg
Roy. This is a
bridge.
Rob Roy and
Yeah.
Ashley question, maybe more than Doc question.
I mean, I like it for single leg bridge for hip rotators. So can you maintain, a neutral pelvis with a single leg bridge? So to me, I think it gives you a nice overall single leg bridge gives you a good evaluation of multiple hip muscles simultaneously.
Yeah.
Rob, we got it. Oh, sorry, Ash, go ahead.
No, yeah, we use it to, you can tell if someone's getting terrible, cramping in their hamstrings when they're trying to do it, then they probably are, pretty hamstring dominant, not using their glutes much or their deep rotators or anything like that. So we do use it from that, but also single leg squat from a functional perspective. Also something to look at.
We have someone, an anonymous attendee. I like these anonymous attendees that send us questions. They don't want us to know who they are, I guess. Is the question is maybe for Rob, is anyone aware of normative data for the hip using handheld dynamometry? Not hand dynamometry. I can't talk tonight. Dynamometry, as Rob said, in like newtons per meter kilogram.
I think
Is there
most people
normative
use the
data?
opposite side. I think most people use the opposite side as kind of standard. The technique is varied. How people do it. Is it a break test? Is it a make test? The position of the hip you put them in. So honestly, I find it more individual therapy. Individual therapists have their own technique, and you need the values comparing it to the other side, and not necessarily to normative data.
Yeah, I actually just looked this up the other day to see if anything had come out recently regarding that, and there's nothing. I mean, there's some stuff maybe in certain populations, very small things are out there, but nothing that's normative across being able to say what's the average for a 20-year-old female, whatever. But yeah, comparing to the other side and comparing their progress over time to themselves, especially with the same tester with your same standards, like Rob said, the way I might do it might be just slightly different than the way Rob does it. So if we test the same person, we may get a little bit skewed information.
Yeah. Hey, Dr. Christoforetti, do you do like when you're doing your clinical exam for hip, do you do tests like this article talked about doing a step down test or like the single leg squat? Do you look at functional things like that?
I'm smiling because I'm the anonymous attendee asking you these questions. I'm just kidding. I'm just kidding. I'm just kidding. No offense to any anonymous attendees.
Yeah.
I think that's a loaded question, and thank you for asking it. Obviously that Brian McGovern is not here with us and on this call, but he was Rob's A+ PhD, stated now PhD himself, and he came and he said, what's some projects? And I said, Hawkins used to do this single leg squat, and if a pitcher was like couldn't do it, then we said rehab can still work, back to therapy. And I can't, the thing you'll have to remember is not only orthopedic surgeons limited of intellect as it relates to full movement assessment, we also have very small boxes to examine people in. Mm-hmm. So we have to find something that assesses the way the skeleton holds itself up. So I've always used that. And interestingly from Hawk, I've always sent to the UFIND folks, and whether it's rotator cuff or whether it's hip, it's always said rotator cuff plus core, or hip plus core and balance, since like I knew what to say about it, and Rob and Ryan helped me look at that. So yes, I do. And what we wanted to do is figure out, can I see a problem the way that a rehab expert, at least can I notice something's wrong? They may know what it is, but I can at least see it. And that's what I was looking for. So we do use that in everybody. We do actually do a heel walk, a toe walk, an Adams forward bend, and that squat. But I don't do the step down test, which I think you guys like better in this paper and others like better. But it's hard in an orthopedic office because they wear different clothes and you're afraid they're going to fall through the window or something. So I put them on the floor. They're just on the floor. I mean, it's just legitimately what we deal with, right? So that's sort of why I do it. But I do use that. And indeed, when we hand that back to one of the folks with skill on this call, or any of those of our attendees who spend that extra time and they're used to listening to the hip, they'll take that patient, and regularly those are the patients that they're like, you know what, let's calm down. I know I've got FAI. Let's check you at the end of the season, right? So, and it does work.
Yeah, I tend to look kind of at both of them, but the paper also talked about the Y balance test, and it looks like Barb Palace, maybe is how you pronounce her last name, sent a question in on asking if we use the Y balance test. I honestly don't use the Y balance test that much because I don't have that. Number one, I don't have the the little Y balance box and the tool for it. But the step down and the single leg squat just seems so simplistic, and you really don't need a lot of equipment. I don't have to put tape down and measure distances and things like that. So to me, it just seems easier. What do you guys use the Y balance? Do you find it really pretty easy if you have the box and everything, or which Ashley and Rob and or Phil and Barb, what test do you guys use?
You know, actually, the Y balance kit that you're mentioning with the boxes has fairly poor correlation to the standard testing because the boxes are give you a different feedback. So it's not really the same thing. And the way to really properly do this, you know, the star or even the modified star is awfully time consuming, multiple
Yeah, I
trials.
agree. Yeah.
You know, so it's just cumbersome in the clinic, and I'm not sure it offers a whole lot of extra value. What I do think we do is use it as a training tool, right? To you know, kind of more gross assessment, and instead of super specific objective, just kind of more qualifying the quality of movement, you know, and then that's why I think that, you know, the single leg squat test is a favorite amongst a lot of people because it's just simple. You don't need it. You don't even need a step. You're not limited by ankle range of motion. You'll find, you know, you're going to have some limitations in knee and ankle range of motion. That's really not from the hip. So I think just the single leg squat is just so simple and easy, and you can give you a lot of the same information.
Is that the same thing you use, Ash, or you use step down two or Y balance? What's your preference?
Yeah, single leg squat. We do step down. We do it a little bit more as like a fatigue inducing test, like multiple reps. We look at kind of the breakdown of how does the pelvis start to shift, does the trunk shift, kind of trying to see what the endurance in that sense is, a repetitive step down versus just a straightforward like single leg on one side, single leg on the other, compare side to side. But yeah, we don't typically we have the Y balance kit. We don't typically bust it out often just for all the same reasons already stated.
Yeah. Do you you know, I'm just looking at my time here, and believe it or not, the time flies when we're on these darn things. And we had two articles to talk about, but I think we're only going to get through one. We may have to have we may have in when's our next open date? Like in April or something. We may have to revisit this and bring both of you guys back because we're not even done talking about this one paper, and it's almost our time is up. So Rob, if you had one test, you would say the step. I'm sorry, not the step down. You would say the single leg squat. Ashley, you do both. You said if you had to pick one, what would you pick?
Are we talking about just for like a quick down
Well, yeah.
assessment?
Yeah.
Yeah, I mean, a body weight squat followed by a single leg squat.
Yeah. Okay. Someone put a question, Sarah Tyndall, do any of you use hip airplane testing for stability? Two variations I've used with dancers: maintain airplane and perform 5 single leg squats with hands to ground and return, or maintain airplane and add controlled hip internal external rotations. First of all, those of you that use the airplane, do you mind? I think I know what she's talking about, but I'm not 100% sure, and I don't want to
Do
assume
you
that
need
everybody.
a demonstration? Should we?
Well, I don't know
like
if you need to do a demonstration. I want Phil to
Come on,
demonstrate.
Ash,
Yeah.
do it. Oh, no,
for us.
Phil. Let's see
Yeah.
Phil do it.
Phil, oh, that's perfect. Phil, you're great
Yeah,
at it.
you're
Actually,
killing it,
you
Phil.
may be
Buddy, you've
better
got
than
it
Dr.
too.
Christoforetti,
Yeah.
believe it or not.
Yeah, and it's essentially if it's the same airplane I do, it's basically a single leg like RDL and then a rotation like opening up, you know,
That's what I
rotating
was.
over the fixed limb.
Yeah.
Like a
We
So
use
do you
windmill.
guys do that for
We use
testing?
it a lot for training, like for just exercises that we do. I don't necessarily use it as like a criteria to pass, if you will. But we definitely use it's in our rehab program.
Yeah, and I
Rob, do
think
you use it?
that gets to the, you know, specific movements that, you know, maybe a dancer does as opposed to a
Right.
catcher or a pitcher. So I think those are excellent. That brings out an excellent point, is that, you know, maybe there's not one test that fits all. Maybe everyone does a single leg squat, and then you pick a couple sport specific tests that are really going to hone in on your athlete's ability to perform what they need to. And if a dancer needs to perform something that resembles an airplane test, then that's a great test, but that's probably not appropriate for a catcher who's maybe needs to do a double leg squat and kind of jump up and be able to throw, simulate something like throwing to second base.
Yeah. What do you guys, one of the last things they were talking about here was like the patients using different outcome tools or making sure you kind of fully understood their psychological readiness. And I know that's huge. I think I think it started in the knee, didn't it? When we really started looking at that more. And then I know it's went to the shoulder. Is it like huge in the hip already or not so much? It's getting, I mean, I think I think we all have to agree it's important, right? I mean, because if some people aren't getting back to their full level because of fear or anxiety or things like that, right, Dr. Christoforetti? We can't you can't like close our eyes to it, right?
No, I think you're right about that. And I mean, mind, body, spirit obviously is a huge element of certain subdiagnoses, probably more than others, and hip conditions where we may see hip instability or we may see posterior hip syndromes or deep gluteal syndromes be in this, category potentially more often, or hip groin syndromes where we're seeing crossover symptoms where you're seeing a patient who's really lost trust, they've lost confidence. A lot of it depends, you see. So if you have a simple femoroacetabular impingement, if that really even exists, but let's assume you have something that's like a patient that's pretty typically everyone thinks it's their hip. I don't personally think that patient is substantially prone to having confidence issues in the same way as an ACL. But keep in mind, I'm going to put that as a caveat. Only the worst will come tell the surgeon. So the lower threshold is going to be with you all. I use the pilot, co-pilot, navigator, as you know, and you all are their co-pilots. So the pilot's going to lean over and say, this is really something, isn't it? The navigator doesn't often hear about that, right? So I would defer, but my intuition is it's usually in these alternate diagnoses. I don't know if Rob and Ashley would weigh in on that.
Yeah, I agree. I mean, we collect the hip RISI on all of our post-ops now over the last 2 years. But the only times I find myself actually going and really looking at it are the ones that typically have a lot of they went into the surgery with some baggage. They had the core muscle stuff. They had maybe their revision. They got told that they were crazy for 2 years before they ever had this surgery. So they don't trust anyone or anything.
Yeah.
But yeah, the straightforward ones, I don't find it near as an issue as with like your ligamentous instability stuff in the knee. Now, the EDS patients that have true instability or anything like that, maybe that's another topic, but there is a hip RISI just like there's the knee.
Were you going to, what did you were starting to comment, Rob? Sorry, I think.
No, I agree. Exactly what Ashley said. I was going to comment on the instability patients.
Okay. What, John, oh, Big Johnny Hanlon. Rob, you know John Hanlon, right? Big Sexy.
Yes.
You know who I'm talking about? Yeah, he's on tonight. He said, how do you guys often assess power production and return to sport decision making? Thanks for joining, Johnny.
Power.
Shout out. Yeah, how do you test power for the hip?
I think jumping, right? I mean, I would get to, kind of more plyometric tests would be some quick and easy ways to do it, right?
Like jump for distance,
lateral jumping,
vertical.
Yeah, I think lateral jumping, trying to fire getting the glute means, I think is what, we found in one of our systematic reviews that seemed to have the most evidence was kind of lateral jumping, trying to get the glute med to fire. So
Ashley, do you do that? You do lateral jumping too?
Yeah, we do a lot of
lateral horizontal jumping too, or anything, or just mainly
lateral? Forward, diagonals, lateral. Just again, what's the person trying to go back to? What's the sport? But we do pretty much on everyone want to see, are they able to laterally bound pretty symmetrically side to side, but distance, good landing, confidence, all of those things. And if you're fortunate enough to have access to something like force plates, then obviously you can get some more clear-cut data on that. They're just still kind of in the pricey category.
Yeah. We have 5 minutes.
I think there was one question I think Dr. Christoforetti was going to answer from Bruno. Do you guys believe the step down / single leg squat needs to be associated with orthopedic tests like fader, or do you prefer functional tests only?
Yeah, I wanted to raise that. I thought it was a nice question. Thanks for that question. And in my opinion, they need to be done in combination. And this is the surgeon's opinion, of course, but femoral acetabular impingement syndrome diagnosis is made with the tests, Bruno, that you're talking about. And then potentially these functional tests may unearth reasons for them to impinge or reasons for them not to avoid that impingement, in my opinion. I don't know if I'm processing that right. Rob, what do you think about that way?
Yeah, I mean, exactly. I mean, so like I initially said, I mean, can we change someone's ability to move? And if someone's got, a very, very significant loss of internal rotation, that really puts that a person's ability to move and our ability to change that maybe a little bit less. So it kind of puts a context into the functional test, and what we may expect.
One of the comments that Brian Kelly makes, which I think is something that I think everyone should hear, is that hip FAI surgery changes the range of motion to increase it at the joint. So it's one of the very few, if maybe not, I think one of the only. I suppose I can't think of a different one aside from none. So let's say it's the only one that we do as surgeons that actually takes the joint arc of motion and increases the available arc, and then that changes the excursions of every soft tissue part and every proprioceptive fiber around it. So there's a comment that we've learned in our surgical literature now, looking into 1 to 2 years or 2 to 5 years, this progressive improver in FAI surgery, where they may already be back to sport, but if you've kind of gotten it right, they're now adjusting, like Rob's saying, to these movements post-op. And we'll see some do better and then better and then better, won't they? And sometimes they'll do better and then worse for a little bit and then better. And that's that deep rehab that you guys do that's so critical. And it's often the very time that the insurance companies and the patients are not connecting that they need to still be there. So, I know that it's sort of a closing swing thought, but this paper let me think I was going to ask you the other panelists about this. How do we improve the communication back to the surgical teams to let that patient gain access to deep rehab because they're going when they need to do those things? Do you guys have any thoughts for any of the surgeons that may have signed in on your journal club tonight?
Oh, this is a very
The deep one.
Yeah. I mean, it's a hard one because more and more, we're in a new year, so we see all the benefits rolling through. And I would say the majority of the ones I see on my schedule, it says, 20 visits per year. Here we go. And we're starting in January. So if they use 20 now, that means at the end of the year, they aren't going to have anything left. And so to your point, I think combination of one, your team approach, and athletes that have access to trainers, athletic trainers, strength and conditioning coaches, having better communication with those aspects. But maybe we need to look at, do we do early stage rehab, maybe middle stage, like when they meet certain criteria, they move to more of like a home monitored electronically type of thing, and then they have to come back starting at like X time point to like finish off and get ready for for the non-professional athlete who doesn't have the luxury of therapy every day, twice a day if they want it, because money is a factor. And we run into this all the time with our high school athletes where they're like, well, we're out of visits, so we're just going to do it with the trainer at school. Well, the trainer at school has every team to manage. They don't have some of the knowledge that they maybe need for this late stage rehab. And then the kid kind of does okay, like you said, but then all of a sudden they're 10 months post-op and they show back up because my hip hurts again. I think I retore my labrum. It's like, well, you probably didn't re-tear your labrum. You just didn't finish your rehab. Yeah. So yeah, I think like philosophically, there's a lot going on there. Rob, you just rehab them all for free till they're done.
Apparently,
my boss loves us.
Yeah.
Hey, Rob, we're down to 293. Go ahead and pull your shirt off, like you were talking about before. We were at over 300. We're like at 293. It's getting toward the end. People are dropping off. I think if you pull the shirt off now, you're going to get some people back in. Yeah, we're going to pull some people back in here to close.
shirtless
No,
physical
for
therapy.
real. For real. Pull it off.
Nah.
No? Okay. Okay. Doc,
After
Rob
you.
was telling us he was going to pull his shirt off sometime during the show tonight to
Oh, that's why so many people showed up.
Right.
yes.
Right.
Yeah.
Well, I don't know. I didn't get a chance to see the list, but I know you're gonna have to close soon. I want to thank any and all folks that are in any of the regions that Isha has touched or that I was lucky enough to serve patients with, and I wish we could see all their faces on it, but it's super cool to see them, and I hope they'll all come to Washington for the meeting.
There you
Yeah.
go. There you
Pretty
go.
excited to be back in the US. So yeah, I think we might have to maybe in like June do another hip one to get everyone
Yeah, we're going to have
for
to. Yeah, with
October.
this number, the number of people that are on this, we got to. Yeah, no doubt.
Hip, it's a hit.
Yep.
Yeah, yeah.
If anyone has certain topics in the hip they want to hear more about, just email me. We can
Make it happen.
Yep.
Doc and Rob, thanks so much for joining us tonight. This was fantastic. I mean, I feel like I say that every month. It's like every month I say, wow, this was fantastic. But like each month it just keeps getting better. So we couldn't have done this without you. We appreciate you so much. Great seeing you both. And we're definitely, Doc, can we have you on again sometime? We know Rob will come on, but we'd like to have you on again sometime too, if you don't mind.
I love hanging out with you guys. You just let me know when.
All right, buddy.
Thanks, guys. Have a great night.
Have a great evening, everyone.
Thanks, everyone. Bye-bye.